Welcome, everybody. Greetings. Greetings and welcome as people are joining the call, joining the webinar today. Welcome, welcome. Today's webinar is Technology's Role in Scaling Quality Crisis Care. Our overall theme is how to use technology to train and monitor fidelity of crisis care and doing that at scale. So we'll be hearing from our expert panel who will introduce themselves in a moment, but let me introduce myself first. I'm your moderator, Ursula Whiteside. I'm a psychologist who worked closely with the developer of dialectical behavior therapy for about 15 years, Marsha Linehan, and I do research, training, and clinical work related to the Zero Suicide Initiative, which I got started in 2013. So I'm currently clinical faculty at the University of Washington, but I run nowmattersnow.org, which is a nonprofit website with free resources focused around storytelling and DBT coping skills. I will turn it over to you, Dr. Julie Goldstein Gromit, to introduce yourself, then hand it off to Dr. Jobs and Dr. Atkins.
Great, thanks, Ursula. I am Julie Goldstein Gromit. It's really a pleasure to be here. I am a clinical psychologist by training. I am with the Education Development Center, a global nonprofit where I'm vice president for suicide prevention strategy. EDC is home to the National Action Alliance for Suicide Prevention. We've been a part of the Suicide Prevention Resource Center since it was first launched in 2002. And I'm also the director of the Zero Suicide Institute that Ursula spoke about, and that will come up in our conversation today. For those of you not familiar with Zero Suicide, you can take a look at the website, zerosuicide.edc.org, and I'll talk a little bit more about it today. And I'll turn it over to you, Dr. Jobs.
Thanks, Julie. Thanks for having us. I'm Dave Jobs. I'm a professor of psychology at Catholic University in Washington, D.C. I'm a treatment researcher and the developer of an intervention called the Collaborative Assessment and Management of Suicidality, or CAMS. I aspire to be an ambassador to the field of what works in the treatment of suicidal risk, assessment and treatment of suicidal risk, and an honest broker about what works. So part of what I'll bring to this is the perspective of a treatment researcher around issues of fidelity and adherence and why that's important in the crisis space. I'm involved in policy and very excited about the new national strategy that was rolled out at the White House in April. So a lot of these things will come up, and I'm very grateful to be involved today. And then I'll kick it over to Dave Atkins.
Yeah, and I am delighted to be here. I am a clinical psychologist by background, was a professor in the psychiatry department at the University of Washington for a number of years. Had the opportunity to work with some fantastic suicide prevention researchers, including Dave Jobs, Kate Comtois, and Marsha Linehan. And the other main piece of my professional life over the last 15 years is really how do we develop AI for behavioral health applications? How is it that we can take some of these new technologies and apply them to really challenging problems in behavioral health care, to support training, to support supervision, and quality assurance. And so we'll be talking more about that. That work that started at the University of Washington has now led to Lyssn, which is a technology company where we are developing exactly these types of technologies. And so we'll talk a little bit more about that today, and super excited to be here.
Great, we'll get started in just a minute. So as mentioned, the 2024 National Strategy for Suicide Prevention was released, and many thought leaders, including our speakers, Goldstein and Jobs, worked on that strategy. So today, within that strategy, there are two goals that are especially relevant to our webinar. That is Goal 8, which is implementing effective suicide prevention services as a core component of healthcare, and Goal 9, which is improve the quality and accessibility of crisis care services across communities. And in the chat, you'll find a link to this document. We'll be inviting our leaders to respond to questions in a moment, but please, as we go through this hour, respond in the chat with your comments or questions, and we'll follow up on those. Today we're focusing on fidelity monitoring recommendations that line up with the Zero Suicide Institute and CAMS frameworks. And we'll be using and discussing how technology and artificial intelligence can be scaled in terms of training to improve crisis care accessibility. And finally, we'll be focusing on the importance of rigorous evaluation of data and technology to maintain high standards. So I will put the first question out to our lovely panelists, which is why is active monitoring of adherence to suicide prevention methods at scale important? And we'll spend about 10 minutes on this topic. Let's see, Dave, you want to turn your mic up?
Thanks, Ursula. So to me, this is a really critical issue that we're grappling with today. When I was first in the field, I imagined myself as a brilliant clinician that just intuitively knew what to do and the right things to do. And when I thought about treatment research, before I was influenced by Marshall Linehan and Greg Brown, who are two preeminent researchers in the field, I really didn't like the idea of a lockstep approach to treatment, protocol where you have no flexibility. But then as I was trying to get grant funding, you can't just sort of intuitively do what you think is going to be effective because you're well-meaning and you think it works. You really actually have to do things that are proven to be effective. One of the things that Greg impressed upon me when we wrote our first grant together was that adherence to domains can leave a kind of a flexibility. So in the CAMS framework, we have a methodology within which clinicians can kind of work in ways that they know to work, as long as they're doing sort of key ideas that are consistent with the model, like collaborative assessment, collaborative treatment planning, collaborative deconstruction of what makes them suicidal and treating drivers. These are elements of the intervention that are so important. And when you do randomized controlled trials, which are the gold standard of what works in a causal way, you really, as a principal investigator, have to ensure that people are doing the treatment as it was designed, to know that you're studying with validity the treatment, and that the other treatment that you're comparing it to is being done as it's supposed to be done. And that is a version of fidelity or adherence that we're talking about today. Why that's important in this domain is because it could be life and death. So I don't mean to be dramatic, but really doing things that are not effective is actually really not acceptable, especially if it leads to bad outcomes. Example I would give you is no harm contracts, used for years, probably with some measure of adherence, but there are now 2 randomized controlled trials and other trials showing that no harm contracts are ineffective. Safety planning type interventions, stabilization interventions are the better way to go. So there are examples throughout my 40 years in the field of things that were done that we thought were effective, people were well-meaning, but maybe weren't or actually could be harmful. So that's where improving things to be effective, we really need them done the way they're designed to be done. One final thought is in a clinical trial that we did with college students in Reno, Nevada, Sam Chalker, who's a former student of mine, published a paper showing that as adherence to the model increased, outcomes were better. Statistically significant finding. So it doesn't have to be rigid, but it does matter whether you do things proven to be effective, doing it the way that they're designed to be done.
Thank you, Dr. Jobs. Other thoughts?
I'm happy
Julie?
to add to that. So what Dave's talking a lot about is at the provider level, which I think is critical. It's right. Providers don't have this kind of training. They're doing really hard work and they're doing the best that they can. But they're not often using evidence-based treatments, evidence-based interventions that we know work. And people at risk deserve that. I think at scale, we can think about it from an organizational perspective, right? We really want to think about what is a healthcare system doing across the system, whether it's a hospital, a psychiatric inpatient unit, an emergency department. What are they doing at scale with every patient every single time? Because there shouldn't be, well, Dr. Jobs has lots of training in suicide prevention, so you hope you get, door number 1, Dr. Goldstein Grummet has less, and so you're stuck with door number 2, right? That's not what you want. It's not fair to people at risk. It should be the same within every hospital setting, every setting where people at risk are going for care. In the community where we're telling people, please tell me and I'll get you help. So when we refer people to a healthcare system, they should be well trained, and there should be standardized clinical workflows at scale. By monitoring adherence to suicide prevention practices, we can learn about what works in a system, where gaps exist, where additional training is needed. You can even look at different populations, what certain interventions might be working well with certain age groups or populations in specific settings. So when we do this at scale and we kind of aggregate all of this data, we have much more information about truly what's working, what training is needed, and how to help people. So I think it's really critical to think about, how does the healthcare system think about integrating evidence-based practices, not just putting the burden on unique providers to go out and seek out training. We really need to focus on doing this at scale.
Thank you, Dr. Goldstein.
Maybe I'll just very briefly add a thought or two to what Dave and Julie have already very eloquently said. I think this phrase kind of fidelity or adherence, can sound, I don't know, kind of technical or researchy, but fundamentally, it's performance-based feedback, and this work is incredibly hard, and so I think another kind of frame here is, yeah, feedback is helpful. And we should be leaning into feedback to just always be thinking through, like, how can we improve? How can we really be making sure that we're delivering the best quality care? And that feedback component is really critical. And I think, working across areas within behavioral health care, one of the really foundational and critical features of suicide prevention care is the severity and the immediacy. And it kind of raises the bar, as Dave alluded to earlier, that, if you have, if I'm doing therapy in an outpatient setting for depression or anxiety, and I, might have a bad session here or there, maybe, you can think about, like, oh, okay, here's what I want to do differently in the next one. But if it's the crisis call center, and like that, it might be your only contact with this person. It's like the bar is higher. Like, we really need to have every single call be incredibly high quality. And so again, I think that that's part of the motivation for wanting to have this type of feedback at scale. And then also really just to think about this as supportive, right? This is really, how do we support, enhance, and augment. We'll be talking a little bit about AI and how that can do it, but just in general, like, this type of feedback really helps us to have the best quality care that we can.
If I might just add on,
Yeah, go ahead.
just a thought. I mean, so we have 5 randomized controlled trials going on of our intervention. And as Dave was describing, we have actually a small army of graduate students that are watching videos. So we get access to basically recorded sessions. And we have a CAMS rating scale to rate those sessions. And that's why you need a small army, is that we have to give feedback to the clinicians. We want to give feedback to the clinicians. What we see, and this is baked into DBT, as Ursula will tell you, is that becomes a very supportive, very validating, very constructive experience for the clinicians. And they are less burned out, and they're more excited, and they feel more ambitious, and they actually want to see patients that are suicidal. So that's a really important component, but not all clinics have a small army. That's where I think technology can actually be a major asset. And there is drift. So even in our clinical trials, where we're really trying to get this exactly so, we'll see people fall out of adherence. And then in a very supportive way, we do some remediation to get them back up to speed. So it really is, it ends up being, as these trials are coming to a close, clinicians are like, oh, I like meeting, and I really like talking about cases. And that's where the support around these challenging cases is so critical. And I really am convinced that AI can be a part of augmenting that support, not replacing people, but actually augmenting what we do.
And I would add, our families and ourselves with lived experience, we want to be able to walk in the door at any organization that provides healthcare, or any call center that we end up being connected to if we call 8988, and have an experience that is high quality. And as we talk about in Zero Suicide all the time, you wouldn't go to an emergency room where they didn't set your arm according to the standard practice. And yet we're sending suicidal people into these places all the time. So I just want to emphasize from the lived experience perspective that many of us are touched by. This is so important. So, and as we now shift topics a little bit to talking more about training, what would you say and how can technology help support training with immense numbers of phone calls and people reaching out? How can we do this at scale to do training?
I'll at least jump in. I think, there was just a study out this week of medical students or residents, and they did a study about, these were interviews, how well do they feel prepared to ask people at risk, therapists for suicide. And their responses overwhelmingly where they felt fear, weariness, overwhelmed, anxiety, shock, and inadequacy. It was a very small study, but I think that's probably pretty consistent elsewhere. And most providers who aren't in behavioral health are getting maybe on average 4 hours to learn about how to assess somebody at risk. So again, as Ursula just said, this is where we're sending people to get help to a provider community who may not have the training to feel comfortable and competent. They may have some of the skill or they may not, but by all means, we want people to have that sense of, I know how to do this. I absolutely feel comfortable and competent to do this and not overwhelmed and fearful and shocked. So I think technology can really support this. I think in terms of, it offers training wherever you are geographically, no matter, what training you had coming up, whatever type of program you went to, whatever healthcare system you work for. There's a lot of opportunity now, I think, to embed training directly into an electronic medical record, so that as you are talking to an individual and certain things pop up, if you don't know how to do it, you can have just-in-time learning to tell you, this is what you should do, this is what you should say. And again, what that does is it really levels the playing field. It means that if you don't know, that what you are going to ask and assess and how you're going to intervene, like safety planning and talking about removing access to lethal means, is best practice. And these trainings are coming from experts, so that you're not in the moment when you're having this flood of feelings trying to figure out what to do and say, and you've forgotten, or it's been a while since you've had to ask. But having access to that training means that people on the ground are going to get evidence-based practices delivered as designed in real time, and they will often allay the feelings that are coming to the provider as well. So I think technology, it's great that we can do this now, and as opposed to having to process it in supervision and say, I felt these things, I didn't know what to do, I'll be better the next time. But the access in real time, I think, is really crucial.
One of the things that Julie alluded to is really crucial. We, across the disciplines, across the guilds, do not reliably get trained in evidence-based assessment and treatment. Across psychology, psychiatry, social work, counseling, all the disciplines, it's not a given. To me, it's one of the issues that with the gatekeeper trainings, where a lot of them involve identifying somebody and sort of getting them to care, predicated on the assumption that that care actually is competent. And what we mostly see, I would contend, in our country is a model that's custodial, where a person who has suicidal thoughts belongs in a hospital and gets medication, both of which sometimes are not helpful and sometimes make things worse. There's lots of evidence-based practices, and yet they're not reliable. Not lots, but there are a certain number of them. But the key is getting clinicians to actually use them. And that's where, when you look at the the implementation, dissemination, research science, what clinicians prefer is to be talked at. That's how they want to learn, but that doesn't change clinician behavior. So what actually changes clinician behavior is a deep dive on the content, role play training, and then consultation. And that's the model that we use, our integrated training model, in our intervention, and that can all be done online. So there's an online 3-hour deep dive of a case in the methodology, a day that's done on Zoom, typically with 50, 60 people, all pairing off and doing role play training. and this really critical component, which is consultation, meeting with other clinicians and talking about cases. All of those are facilitated by technology, and that's how clinicians change behavior. So we've got a problem. We've got a model that is out of date, where we default to hospitalization, ED care, which I would contend is probably more often problematic, taking somebody out of their environment and then not doing things that have been proven to be effective. So I think technology is a key component into transitioning into a model where we're actually training to and providing effective care.
Thank you. Dr. Atkins, can you comment on that, or can you talk about the ways that you're currently using technology and AI for training?
Yeah, absolutely. I think one of the kind of foundational perspectives that we bring to this at Lyssn is just thinking about, um, fundamentally behavioral health care. The treatment is often a conversation, and so, but it's a skill. It's a skill like any other skill, and so we often will kind of draw parallels to uh, how we learn other skills, where that could be a sport, could be a musical instrument, could be surgery, learning how to do surgery if you're a surgeon in training. And what we know from learning skills in general is that there are two really foundational pieces, which Dave was already alluding to, but is many opportunities to practice and expert feedback on the correctness of the practice. And that is really hard to do when it's a conversation, right? Because so role play can be critical, but so how do you simulate a very realistic patient or client encounter? And then how do we provide immediate expert feedback on the practice? And so those are really the two hallmark pieces for us at Lyssn that we have tried to develop technology and AI to support. Is how do we have realistic practice, so it's not a simulation where you get a multiple choice question. Now would you like to A, insult your client, B, make a supportive statement, but you respond as if you are seeing this client, and then in real time the AI can transcribe what is said and evaluate it for fidelity, provide that performance based feedback that we were talking about earlier, so that if you are learning to effectively assess for lethal means, you get immediate feedback on how well that happened. And so I think it's those two pieces of practice and immediate feedback is kind of the North Star that we try to point our technology towards.
Can I ask, Ursula, I'm going to jump in because I
Thanks.
actually am going to ask you a question, Dave. So that, which would be, it seems to me, right, when I was getting trained, AI obviously didn't exist. And so all of this practice was with your supervisor or your peers. And I would wonder what the research says about people's level of comfort in practicing via AI instead, because it kind of takes out that nervousness potentially of being judged by your peers or by your supervisor.
Oh, 100%. I mean, it's like, again, any of us, when you're first learning any new skill, it's like you kind of want to do it on your own, but you need that feedback as well. And so I think that is definitely a component that people like, is that ability to have a simulated role play, if you will, but kind of out of sight of your peer or your trainer. And so 100%, I think that is one of the advantages, one of the things people like about it. And then I would just also say, like, with role plays, like, it's challenging to sustain role plays, having done many in my life, both as trainee and trainer. And so I think it absolutely is kind of one of the best things that we've been able to do in kind of relying on the human training process. And I think it's one of the ways that technology can really scaffold that and augment that in important ways.
So digging in a little deeper here, like when we remember our training and we think about the people who supervised us, often individually, the sheer number of hours that it takes to supervise people up to a level that is adequate even. Um, that's a huge part of the struggle, is the number of hours it takes to train people and I guess to supervise them and support them as they're going through the process. So I think the question is, maybe it's first to you, Dr. Atkins, like how can technology in this case support the supervisors who are trying to help get these people to Fidelity and also to monitor quality assurance?
Yeah, and Dave Jobs alluded earlier to the kind of army of graduate students who are reviewing tapes and generating this performance-based feedback. And within suicide prevention care, Lyssn is working most closely with call centers, some in the 988 system, some outside. And what we see there is that our partners who are uh, expending incredible resources to similarly try to generate that type of quality data, because they know how important it is. They know how critical it is to have a line of sight into the quality of services and use that for supervision and quality assurance. But it is incredibly resource intensive. And so, the AI, the goal really is to have AI take the place of kind of an expert human evaluator, one of Dave Jobs' graduate students. And the goal is to be able to generate that performance-based feedback directly from a recording of a, in with a 988 call center, a crisis call. But the goal then is to really augment, whether it's the call taker or their supervisor or the quality manager, to provide that information so that they can then provide feedback, identify where are the strengths of this particular provider, call taker, where are skills that they need some additional practice on. But the AI can generate, again, can replicate the army of graduate students, and the AI doesn't get tired. And so it can provide that feedback, not for a call or a session here or there, randomly selected, but for all of the calls or all of the sessions. And I think that's really the power that we see. We published a paper earlier this year. It was a collaboration with some folks at Talkspace, and this was not specific to suicide prevention care. It was more general outpatient, but the AI analyzed 22 million conversations from 176,000 clients, 5,000 providers. And you can see the power at scale. And then Talkspace measures outcomes, and so we could see how the types of fidelity metrics, this type of performance-based feedback that the AI develops, map to who was improving in their depression symptoms and who was satisfied with services. We're talking about that perspective of clients coming to receive services. The quality of services as detected by the AI maps to who was satisfied with the treatment that they got. So I'll stop there. But yeah, that I think that the ability of the AI to generate that feedback, and then to provide that kind of throughout the organization, at the level of the individual provider and their supervisor and quality manager, it really helps to create that learning environment system, right? That the organization, the healthcare system can learn and improve across all of their services.
Yeah, AI doesn't also graduate. So, I mean, every fall we have to gear up and train a bunch of new grad students to do this. So I really am keen on this idea that this could be brought to scale. One of the things that I associate too is we've seen since COVID in a lot of the clinical trials, younger providers in the clinical trials versus licensed professionals, they're very receptive to feedback. They like data. They don't have attitude. and they're really on fire to do things that are effective. People my age, really tough. And it's understandable. I spent 40 years becoming the clinician that I am. It's hard to, change my ways. One of the things that I think that AI can bring to the table, a couple things, is a menu of options or tailoring the kind of learner that you are. So you don't have a one size learning approach. You have multiple ways that people learn. And the other thing that we clearly know, dabbled a little bit in avatars and working with Linda DeMeff and Kelly Kerner, and people with shameful topics are much more interested in talking to an avatar than to a live clinician. When I was working at Fort Sam Houston with one of the early telehealth ventures during the Afghanistan war, soldiers coming back to Fort Bragg, it's been renamed to Fort Liberty, I can't remember what the new name is, but coming back from Afghanistan from deployments, were given the option of talking to a live clinician or to somebody at Fort Sam Houston in Texas online, and they preferred the online person, and they disclosed more. So there are cohort effects in this, and with younger people, I think we're going to see more and more interest in technology. It's also been the great democratizer since COVID. Telehealth has catapulted us into a completely different mindset about doing treatment, especially in remote and rural parts of the country. So it seems inevitable, but it also seems that we don't have to throw the baby out with the bathwater, that it's not replacing people, but really optimizing and scaling what the possibility is to maximize our use of people, and then having farther and wider and more impactful reach for effective care.
Yeah, Dr. Goldstein, do you have responses to that? Or I know you've been thinking about equity as well in this process.
Yeah, I mean, I think a few things. I think it's certainly, again, people, even supervisors have different levels of experience and comfort and training. And so again, having access to AI as a training tool, I think really provides equity for people, nationally and globally in terms of accessing treatment, accessing training to deliver effective treatment and care. Because when you talk about it at the scale that Dave is talking about, the way in which people are accessing this training, then you really do have the ability to learn so much from that. I think the other thing that I'm so mindful of and was so blown away from is in suicide prevention, it's not just the evidence-based treatments that matter. Those matter. They reduce suicide behaviors and ideation and deaths, and delivering on those, right? Safety planning, talking about reducing access to lethal means, carrying contacts, all of that, treatment specifically, right? DBT camps, all of that matters. It really matters. But it's not just what you do, it's how you do it and how you make the person feel. We know that people often drop out of treatment. They come to 1 or 2 sessions at most. They're not feeling like they're really their provider's not supportive or telling them how they're going to help them. They're not really offering that hope. I got you, and this is what I'm going to do, and this is how we do it, and this is how you're going to get better, and stay with me. We sort of black box it, right? I have to fill out all this paperwork. Next time you come, I'll finish up the paperwork, then we'll start. But I'm not going to tell you what it is I'm going to do. You're just going to come, and I'm magically going to orate until you get better. And we don't do that on medical care, right? In medical care, you're diagnosed with X, and then you have your first appointment is this whole menu of exactly what's going to happen and when and how and who has to drive you home and how bad you're going to feel and on what timeline and what your prognosis is. We know so much about that in suicide prevention, but we hold back from sharing that with people at risk. And I don't know why. I mean, I do know why, I think, because I think providers are afraid. Because what if, right? There are people who will go through treatment and will ultimately potentially go on to kill themselves, and that's horrible, but the majority of people won't. And I think that we can use these interventions, and it's our job as clinicians to do that. And I was blown away by this, by the use of technology to really pull out elements of hope and empathy in the session, because I think that the ability, again, at scale, what does this look like? How well am I doing? In the moment you miss things, and AI can hear things that we don't hear because it is able to listen much better than we are and to report back to us how many times a person in treatment said particular words or phrases that, when your mind is like thinking about 12 things at once in the session, you miss. And having armed with that data is great because it can really help the clinician feel much more prepared. But also, what do I look like as a clinician? I think I'm really empathic, but what if the data says I'm not so empathic? Ursula's far more empathic. So great. How do I learn to be more empathic? But I don't know what I don't know. And so, I'll judge myself to be empathic, but when the data is in front of you, I think it helps you to really expand and learn. And I think really clinicians, really providers, they really are scientists, and they really do want their care to be data driven. Nobody wants to think that what you're doing is not helpful. That's not why anybody went into this field. And so I think people are very open to using data to improve their care, and it's objective. And so when you use that, I think that it can be incredibly powerful, both for the person at risk as well as for the provider.
I liked what you said there, Dr. Gromit, or Goldstein Gromit. It's like, as we move towards a standard of care where, these are the expectations for best practices, it may be easy to fall away from being human in the session. And some of these adherence measures are really about being a human, providing hope, being present, all of these things. We did have an audience question. I think that's for you, Atkins, which is, how do you, kind of looking at it from the other end, but how are you approaching ensuring that your AI powered feedback to trainees adheres to whatever model that you specified for this?
Yeah, it's a great question. So just conceptually, let's look under the hood a little bit at AI. And again, the goal is that the AI becomes like an expert human. And the way that we do that is we have to train it with many, many examples of actual expert human judgment. And so Dave earlier referenced the CAMS Fidelity system, but for pretty much every evidence-based practice that I know of, there's going to be some standardized, clinically validated system for what does quality look like, and it varies. If DBT is different than CAMS, is different than CBT, but we have these clinically validated systems, and so at Lyssn, what we do is we have a team of mental health professionals. We call them our clinical AI team, and they are reviewing sessions, and they're providing this expert, reliable, valid human judgment. Things like how empathic, using a standardized, clinically valid rating scale of empathy, how empathic was the provider in this session? And then what AI is really good at is pattern matching. And so when the AI gets to see a transcript or a recording, and then paired with the expert judgment, this was a really empathic session. This was not a very empathic session. This was an excellent example of suicide risk assessment. This was not. The AI then can start to learn the associations. So what specific words, what interaction pattern between the provider and the client, even the vocal tone and inflections in the voice. It will start to figure out what is it in that recording often that led the expert human to make its judgments, to say this was really empathic, this was a great example of a suicide risk assessment. And so that training component is really, really critical. And I'll just make two brief comments, and we might want to talk more about this, but AI has been talked about a lot courtesy of ChatGPT, and there are these kind of off-the-shelf general systems like ChatGPT, and they can do many amazing things, but that's really different than having a well-trained system that has been trained on this expert level human judgment. And so that is one of the things that as a potential consumer of AI is really asking these types of questions, right? How was that AI trained? What if you're telling me that this AI is going to evaluate empathy? Like, what definition of empathy are you using? And so those are really critical. And then that training data also needs to be a good match for where you're using the AI, right? That if you could conveniently get access to some recordings at the student counseling center where you're a professor, those may or may not be good examples for suicide care. And what are the demographics? As are those training sessions good examples again for where you're going to be deploying that AI? So that there's some important issues around ethics and equity in terms of how that AI gets trained and making sure that it's providing accurate feedback. So let me pause there because I can get rolling on AI.
Yeah, we'll be getting into this next, and then after that we'll have time for a few questions. If my lived experience team were here, they would be cheering, because the fact that you are looking at tone and an inflection, I continuously get this feedback that like it is about the way that they are interacting with me, much less so what they say, and I am monitoring what I think they're open to based on their tone, and I will say more or less about my experience based on that. I will not tell them I'm suicidal if I can tell they're in a hurry, for example. So thank you so much for commenting on that. So to continue the conversation about, you were alluding to a bit, we want to have a discussion now about some of the technology and AI risks, and the importance of proper assessment. So why don't we continue that there? I'm not sure if you want to kick us off, Atkins.
Yeah, I mean, at a foundational level, the risk. Whoops, did we just lose Ursula? Hopefully she'll come back. Yeah, at a foundational level, the risk really is around that training piece, right? Because if we're now going to take AI and we can deploy it across hundreds, thousands, potentially millions of calls or sessions, then any potential bias that could be in that AI gets multiplied that much. And so that is a significant risk, and is one that we can control and monitor. And one important piece here is AI software is never done. Like we have to be continuously validating and calibrating it. And again, the fundamental piece is, what data was that AI algorithm trained on, and is that representative of where you're now using that AI algorithm? And so it really is critical that we have very diverse training data in sort of every understanding of diversity. And at Lyssn, we will know sometimes that it's like we're going into a new setting and a new population. One of the examples that I use is we, courtesy of the Annie E. Casey Foundation, partnered with Covenant House New York City, which is a social service agency for homeless youth in New York City. And we knew we had never worked with a homeless social service agency prior to that. And so we went in knowing that we were going to have to evaluate and calibrate the AI models, because even though it was, in this case, motivational interviewing, and we had experience with that, it's a new setting, it's a new population. And so that's, I think, the kind of careful monitoring and being attentive to and close to the training data. And then specifically at Lyssn, we now have a yearly report of, we call it our bias report, but it's really scrutinizing our AI algorithms specifically for potential bias across diverse providers, so that we're guaranteeing that the type of feedback that could come to me as a Caucasian male provider is equally accurate as it is to a Black female provider or someone from the LGBTQ community. And so we update that and publish that yearly. Again, where I think a key principle for AI development is transparency. Can you be transparent about the training data? Can you be transparent about the potential bias? Can you be proactive in examining that?
Dr. Goldstein, do you want to add on some of the thoughts that you've been having about this topic of safety and risk in AI and technology?
Yeah, every time I talk to you, Dave, or one of your colleagues, I'm just more impressed, frankly, by the quality and the thought that goes into your tools.
It's very sweet of you. Thank you.
Taking, but I am. I mean, learning about this bias report is not something you've shared before, and I think that's fabulous and so important. What I was thinking before that, or separately, was just the flood of tools that seem to be coming on the market, and that report to do things like that, that purport to train clinicians or to use AI. I think the things that I worry about are twofold. One is, I think whatever AI you're going to use, or technology in general you're going to use to enhance care in mental health, know what it does, know who it's designed for, know what its results are, and the kinds of things that Dave is talking about in terms of its commitment to evolving, its commitment to equity, its commitment to sort of an annual report in that way. Because I was at an event last year. I think there were over 200 technology companies for behavioral health. I had heard, and I've been in this field and in suicide prevention specifically for over 30 years. Of the 200, I think I was familiar with like 6. I couldn't believe it. It was exciting. I mean, to sit where I am, I think it's amazing and it's exciting. And my kids should only get better treatment and care, as they need it, and for their children. But I can't imagine all 200 are still going to be in, functioning necessarily. Some things got to rise. I hope they are, but only if they're really high quality. So that's kind of one thing. The other thing that I'm mindful of, I think, and I think clinicians have to help their patients, which is so many things now are direct to consumer, and consumers, patients, people at risk, families, loved ones are eager to certainly find the $1 million solution to take care of their loved ones or themselves. And I worry about, we don't currently have quality standards in place to ensure that these are of the highest quality. And so again, I think it's our job to understand what we can and to educate our families, our loved ones, our communities, and certainly our patients about the risks that may be in as part of anything that you're using, that you're finding on the internet. It can be amazing, as we've talked about. It can reduce stigma, access, time, again, geographic lack of providers. I mean, there are many wonderful things that can come with access, but I think there are risks as well.
Dr. Jobs, what are your thoughts and comments?
Yeah, my thought is the all or noneness of this topic. I think about machine learning, which is a methodology that creates algorithms that potentially routes people to different treatments based on large data sets and iterative models, and learning how to think about who belongs where. And there are people that just vilify that. It's like the worst possible thing that could ever be. And we miss too many people that are suicidal and just completely trash it. And there are people who feel like it's the be all and end all, when the truth is somewhere probably in the middle. I'm a fan. I wrote a paper that one size doesn't fit all. And for 16.6 million Americans with serious thoughts of suicide, we really need a lot of treatments, a lot of interventions. And so I'm a fan of Ron Kessler's notion of precision treatment rules, that we can have data inform different treatment avenues that might optimize outcomes, save money, and you don't have a hammer where all the world's a nail. You have different tools for different need sets, and we can rely on data to help guide that. Is it 100% foolproof? No. But you think about the millions of taxpayer dollars spent in the VA system, for example, to teach clinicians prolonged exposure for PTSD. Do you know how many clinicians actually use prolonged exposure in the VA with adherence for PTSD? I don't, but I bet you it's mostly students and young trainees that are doing it with adherence, and literally millions were trained to that workforce. So I feel like it's not either all. It's not all or none. It's both and that's where I think Dave will very clearly say we're not trying to replace humans. We're trying to optimize the human component, but also this has the potential to bring it to scale and be much more efficient and provide much better care at scale.
Yeah, I think to add on, we have a question that is about this. Let me just ask the question. So, as this well-trained system evolves and gains expertise, how long before humans are no longer beneficial to providing treatment? So, the way down the road, or maybe not so way down the road, like, what are your comments or thoughts on that?
I have one immediate comment. We have an intervention called Jasper Health, which is a tablet that's used in emergency departments. We budget 4 to 6 hours for the patient to engage, and all they're doing is engaging with this tablet experience. Elements of CAMS are baked in, elements of DBT are baked in, lived experience stories. No one likes the emergency department. On average, it takes something like 10 to 15 hours to see the doctor. That is a prime example of a technology that can be brought to bear. Patients love it. They get much calmer. They get much more regulated. They learn skills. And if they get bored with that, they can watch puppies playing. And so, that's to me a beautiful example of what technology can uniquely do in a setting where famously people hate to go to the emergency department, especially mental health folks, because they get triaged over. And they spend a day, they get boarded overnight. They get boarded for multiple days. So that's an example of, can't miss with that. That's just a useful thing. You're then getting the doctor a very thoughtful report that they wouldn't have otherwise gotten in their 15, 20-minute interview when they finally do show up. You're meeting joint commission requirements. That to me is like a no-brainer. But it's not for everybody. And it's not for every setting and not for every situation. So that's where I think bringing technology to match certain need sets, like sitting in the ED for 10 to 12 hours, is sort of an obvious thing to do, but not the be-all and end-all.
Yeah,
And certainly in line with this, and certainly in line with this idea that with these 16 million plus people seriously considering suicide a year, there's going to be there's no deficit. Like, there's so much space to fill before we would even approach not needing humans. But what were you going to say, Dr. Atkins?
Yeah, I was just going to say that, clearly we have challenges with access to care here in the US. When you get outside the US, like access to competent behavioral health care is even, 10, 100,000x. So I think if we just start from like, is there a potential need for AI assisted care that is actually extending, not just supporting humans, but actually providing some level of care? I think there's a need for it. And I think we need to be incredibly thoughtful and think about what is the appropriate clinical validation. And at Lyssn we think about that in terms of what are really like the subclinical ways that AI could be supportive directly, and that might be able to assess and monitor when this is more of a severe, risky individual who would need to get routed to treatment. And so I think, for us, that's really the starting point. There are startups, maybe one of the 200 that Julie bumped into, who are already talking about AI therapists. That makes me incredibly nervous. Could it ever get there? I think so. And it would certainly require FDA approval, because if you are diagnosing or treating, that's when the FDA gets involved. So I think there is the possibility of that, and we see with ChatGPT and other similar systems that they can have very realistic conversation. So I think that is allowing some folks to get excited about the potential for an AI therapist. I have significant concerns as an AI developer that we go too quickly in that direction. I think we want to be very, very thoughtful with how we move in that direction. And I think the clinical validation, the research validation is going to be absolutely critical before we ever actually truly got to that point.
And I think the thing that I would add, and I don't actually, what I know is that technology has enhanced surgery, right? There's ways to use technology to, to do better surgeries with more precision. And I don't know, but I don't have the sense that doctors think that they're out of a job. I think that we still need individuals who have, the reasoning and thinking that we do, but it certainly helps to fill a gap in a space where precision can be helpful and better and supplement what we're doing. And I think the same is true here. I think this supplements therapy. I think it augments. I don't think that it replaces. I think that it increases access. People are only with their clinicians for an hour a week, 2, 3. I mean, if they're kind of at more acute risk. I think that we can use technology and AI for so many hours outside of that. Think of training of the loved ones and how do they support somebody at risk. Think about all the hours somebody isn't in therapy and says, but I'm not sure, what did you say, or how do I do this? And it can really augment that. But people still want relationships. We learned that this year, right? The Surgeon General talked about connectedness being one of our biggest challenges that we lost during the pandemic, and that we really, as a country, need to go back to. I don't think that's over. I think that people want to connect with other humans, and that's what therapy and individuals are for, and that's not going away. But if we can do what we're doing and help somebody to get better with more precision and faster, we want people to go on to have hope and recovery and not be in therapy forever. So I think it's an exciting time, and we need to focus on the positives that come along with it.
In a moment, I will ask the panelists to share a final thought or something they're most hopeful about in terms of this area. First, I'd like to get maybe one comment on one question related to what Julie was saying earlier. Well, Dr. Goldstein, with new AI technologies popping up every day, can someone elaborate on how AI can be utilized in mental health services and be validated? So can you elaborate on how AI utilized in mental health services can be validated? Or answer the question in relationship to lots of technologies popping up and what do we do with them?
Yeah, I mean, I think we're headed to the point where we'll have some actual AI regulations. They're not here yet. If you look at the proposals that are out there, really the kind of foundational principle is around transparency. Transparency in terms of how the AI was developed, appropriate settings and populations where it can be deployed. And so I think that would be one very critical thing. For us at Lyssn, we're all scientists at heart. And so I think research validation is critical. And we publish scientific papers, and that's part of our transparency as well as part of the clinical validation. So I think just briefly, those would be my 2 quick responses on that.
Okay, so in a sentence, what's your take-home message here? So I'll start here with you, Dave Atkins.
Yeah, I think it is a really exciting time, and I think there are ways that AI can really help to support and augment our human providers who are on the front lines of really the crisis of suicide care. And we need to be really smart and transparent in how we deploy that technology.
Dr. Jobs.
I would say that we're at an inflection point in this field. I've been at this field since grad school, 40 plus years, and I really do see a tipping point in terms of interest, focus, will, and technology as well as skill. 16.6 million people with serious thoughts of suicide is a massive population, 300 times greater than the number that die. We need all of it. We need skilled clinicians. We need technology. We need a mental health workforce. We need paraprofessionals. to tackle a problem as large as this one. And I think AI is obviously a part of that picture.
Thank you, everyone, and to you, Dr. Goldstein.
Yeah, I think, beginning where we started, which is a lot of clinicians don't know how to do this work. Well, they're not trained. And so I think using AI and technology just really ensures that people at risk are getting evidence-based treatment as designed with Fidelity. It increases their likelihood of reducing their suicide thoughts and behaviors and attempts and deaths. And that's what we want. That's why we went into this field. And so we should be using everything at our disposal. And I think it's great that we have new technologies to improve that care.
Thank you, everyone, for joining us. We hope you have some great takeaways. We appreciate you being here today.
Yeah, thank you so much. Thanks, Ursula.
Yeah, no problem.
Thanks, folks. Bye-bye.
Bye. Thank
Cheers.
you.